calcification of the anterior capsule. So this is exactly what could happen. Let me go back again a little. What will happen to me? I was trying to assess the flap as I had raised it up through the main port, and I could not. Okay, so I want to ask a question here. Dr. Norat, please. I don't know who else is observing what I am seeing here. Why couldn't I access that flap? This is my flap here. Why couldn't I access it through the main port? Okay, let me answer it at once so I can save time. The fulcrum effect I mentioned, you could see the nasal, am I correct? Yes, nasal margin of my incision here. So this is the tunnel of the incision. This is the nasal margin, and difficult area to work on is a clock hour and 2 clock hours from the margins, either nasal or temporal, of your incision. So I tried to assess this flap as I had nudged it out from this point, and I could not. And before I knew it, apprehension set in. Every adrenaline I told to leave me alone, they all came back. So let's continue that and see how I managed to survive. Each time I try to assess it, I will not. So I now had to go through the side ports. Those are decisions that will face us on table. So through the side ports, took a grab, it wasn't firm, I left it, made it firm. And the only option was centripetal. That means a motion towards the center. Now I can go back from the main incision, I could access it now. So I have done the initial small rhexis so that I can decompress the raised intralenticular tension. So with a decompressed intracapsular bag, it will be easier to finish up the rhexis and also to make a good effortless nucleus delivery. Now, if one is going to do such a decompression, you are advised to engage in the suction mode, or sorry, aspiration mode, because your fluid is going in. If there's no counter aspiration, at the time you direct your either your bimanual or your Simcoe into the intralenticular space, you might inadvertently add more pressure, add more intralenticular pressure, and you might lose the bag. It might give you an Argentina flag sign. So when the instrument of choice, here I'm using a Simcoe, or if you are using a bimanual, please, you are advised to engage on aspiration mode when you are facing the intralenticular space. Now, I want to reform the anterior chamber, and what I did was I went behind, this is the intralenticular opening, but I went behind it towards the iris diaphragm to reform the anterior chamber. The reason is simple. If you direct this cannula this way into the intralenticular space, the pressure you have decompressed, the visco will fill it up again and the bag will give way. So that's why anytime there's attempted recompression of the anterior chamber, it's always advisable to go behind the area of the initial rhexis, the small rhexis. I mentioned yesterday that you could use scissors. So that was me using scissors. Again, look at what happened to me. Why did it happen? Because of this difficult to access area in rhexis. So I now use scissors through the main incision, through the side port, and I finished up the rhexis. I think I use the microfaucet to finish up. But just to know that scissors is always handy when it is needed. And I have to overcome this area of calcification. So this is the rest of the rhexis. Hold firm, centripetal pull. Make sure it's firm. Centripetal, 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 and I am done. All right, thank you, everybody. That was how I overcame these difficult Rexes. If there are any questions, please, we can look at the questions later. Position properly. All right. I achieved my puncture, held my flap, directed to desired perimetry, and classification. That was classification. Any further advancement by my judgment would have endangered the zonos. That was my immediate judgment at the time. So I had to stop. If one notices carefully, you will see that when you reform the anterior chamber, it looks like the the capsule is bigger. But when the chamber is shallow, decision making is a little difficult and actually might be faulty if anterior chamber is shallow. So the best to do is to have a well repressurized anterior chamber so that your decision at least will be fair enough. Now, in my opinion, I have overcome the calcified area or the difficulty I met initially that made me stop. So now I have to go back in with my microforceps. So I now tried. This is circumferential now. Let me see. Circumferential, 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 centripetal, 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 weak zonals, centripetal, centripetal, centripetal. All right. So whenever I see classification, like I mentioned yesterday, it's a pointer to a much more bigger problem. Let's look at how we manage these rexes. I don't know why I put it here. Maybe it gave me difficulty. Let's look at why the difficulty. My dominant hand is my right hand. So most times my entry wound is usually between 12 o'clock position and 11 o'clock position to give me the advantage. Okay, let's see what happened here. Why was it a difficult case for me? Oh, okay, I see. Now, it went beyond my desired perimetry, poorly dilated iris, and I am not seeing the margin of my capsule. So I'm practically finishing this rexis on centripetal motion only from beginning to end. Centripetal motion from beginning to end. So I'm going to manage, as it were, the rest of the surgery without seeing the margin of my capsule. And I'm noticing the iris coming down on me. So I suppose that is why I labeled this a difficult case. If, okay, that was me using Visco to check the margins. And I'm not sure I saw the margin, so I just did a little rocking on that Visco cover. I wasn't rocking without Visco cover. It's not safe to rock in nucleus without Visco cover. I'm not too sure, I really know why that's so, but I know with Visco, it's easy to have retraction of the capsules, and Visco will keep the capsule still far down. So the Visco reforming the anterior chamber at each one time there's a motion, we at least keep the capsule down away from you. I think we should revisit this nucleus management later on. I'm trying my best to be sure that I am not going to put the capsule in jeopardy. So there'll be a lot of visco motion. Okay. This was why I had mentioned earlier on that sometimes you can misjudge your length of specification classification as done in the clinic, only for you to meet a bigger, denser nucleus on table. So my advantage here was that ideally I had already made a larger incision. So I have a lot of space to maneuver around. And it's a reason why our teachers used to tell us that visco is cheaper than corneal endothelium. So trust me, I'm using every maneuver in my head at this point. I'm not following any particular pattern. At this point, anything that works under visco cover, I'm doing it. Maybe I should mention that the woman had her good vision after the surgery. So that's like a relief for us now, because me watching this, I'm like, how did this happen? Some people will use their vectors, either irrigating vectors or non-vector under visco cover. But before I use vectors, I must make sure that the capsular bag is far away from me. Before I put irrigating vectors or non-vectors, I make sure that the capsular bag is far away from me. How do I do that? Pushing visco. It deepens and it deepens. I'm repressurizing back the anterior chamber from the side port, because anything I do from the main port, I do not know how safe or how near towards me the capsule is. So I have to go to the side port to repressurize back. Now, just to see the posterior capsule before I attempted escorting the rest of the nuclear fragments out of the eyes. If I do not see my posterior capsule, I'll be careful in what I am doing, because your cannula might just puncture the capsule. Right? I think that was why I included this as a difficult case. If you're interested to know the amount of visco used here was about almost 10 minutes. Okay, so this is how to do hydrodissection. Let's look at it. Hydrodissection is the beginning of nucleus management. Hydrodissection is the beginning of nucleus management. The rule of the game is simple. Because you're going to introduce additional fluid into the eyes, you should have the anterior chamber not turgid or filled with visco. So if there be any visco filled up in anterior chamber, it's good to escort some out. Reason again, because you're going to add additional fluid to do the hydrodissection. What is hydrodissection? To separate the nucleus or the nuclear component from the capsular bag, from the capsule, to cleave it off from the capsule. Hydrodelineation is when a surgeon, in his judgment, thinks the posterior capsule should be additionally protected. So you direct the cannula into the substance of the nucleus and split the endonucleus from the epinucleus. So the posterior epinuclear shell now shields the posterior capsule further, while the endonucleus is attended to. So hydrodelineation is when you split the endonucleus from the epinucleus, while hydrodissection is completely separating the nucleus and nucleus from the capsule. So I have a funny way of doing my hydrodissection, which I learned somewhere else. Before, I used to do hydrodissection with any caliber of syringe given to me, 10 mil or 5 mil or 2 mil, whichever is available. But if you look at the laws of physics, I think the best plunger to use is a 1 mil insulin syringe. To the best of my knowledge, that is the best syringe to use. If you have access to 2 mil syringe, it's okay to use 2 mil syringe. In terms of cannula, the best cannula to use for hydrodissection is a 30 gauge cannula. If 27 gauge cannula is available, it's okay to use. Anything less than that, you have to be extra cautious. The reason is simple. To achieve a jet of fluid that will do the cleavage of the nucleus from the capsule, one requires a particular gradient of force and also a particular gradient of volume of fluid. If I am using an insulin syringe that I can detach freely and put a 30 gauge cannula, that means if I use any small amount of fluid, let's just say 0.5 mil of fluid, and I press it by force, I will achieve a very fast jet of fluid that will cleave the nucleus away from the capsule, and I will not have used a large volume of fluid. If one is using a 5 ml syringe or a 10 ml syringe, given at random, not necessarily that you ask for it, given to you at random by your assistant, either 5 ml or 10 ml, and also you are using a 23 gauge cannula or 25 gauge cannula, to achieve such a jet of fluid that will do the cleavage, you must have used a large volume. So that is the theory behind using a small caliber syringe and um, a small caliber cannula, because you get the same jet of fluid faster with a smaller fluid. What I do, which is common to me, is this. I ask them to load in a 2 ml syringe 0.5 mils and give me, by default, 27 gauge cannula. When I'm giving that, I make sure that I express some of the fluid out of the cannula, leaving in the cannula 0.3 mils. It's my habit. I do it every time. It's better I go back to get extra fluid to complete it than to burst the posterior capsule. So let's look at it this way. By the time any extra fluid goes behind the capsule, it's going to move this capsule forward. And the capsule that's moved forward will come and form a tamponade on the anterior capsular ring. That also means that further fluid in the eye is not moving in any direction. Further fluid in the eye is only waiting to burst the capsule, because the fluid has pushed the nucleus component forward and it has obstructed any part of the anterior capsular ring. So that's how I set my instrument for caps and for hydrodissection. So let's look at hydrodissection as was done in this case. All right. So that's the cleavage. I did not achieve complete cleavage at first time, so I had to tap on the nucleus at the center. Center because the curvature of the nucleus will at each one time leave you a meniscus of fluid underneath. If you tap sideways, the meniscus of fluid will still be waiting for you. So I took another quantity of fluid. The cleavage is now complete. So that is hydrodissection. So let me see if I can go through it again. Okay, sorry. Okay. All right. So someone asks, how do I introduce my cannula? Now, underneath the anterior capsular rim, introduce up to 2 millimeters, if not more, into the space between the anterior capsular rim and the nucleus. Advance it, steady your hand. Motion in and out at this point will not achieve a fluid wave for adequate cleavage. So when one has advanced the cannula into the space between the anterior capsular rim and the nucleus, steady the hand, then press a jet of the plunger, the fluid will jet out. It's always advisable at this point not to move the cannula in and out, because if it comes out, the fluid will bounce back on you like a reflux. So it doesn't do any cleavage. So, and it's advisable to check if your microscope has a retro illumination component, so you can switch on to retro illumination. It's easier to see the cleavage under the retro illumination. It's called a fluid wave. Now, what o'clock position is advisable? It's advisable to do your hydrodissection at directly 8 o'clock position. This is 8 o'clock position. Knowing that this is the surgical 12 o'clock position, this becomes the 8 o'clock position and 4 o'clock position, because it will not make your hand too angulated at 9 o'clock position or 3 o'clock position. So straight 4 o'clock position is a more it's a better compromise, and 8 o'clock position is a better compromise. But then I finally have this theory. I do my hydrodissection where I have capsular advantage. If in my rhexis there was no capsule advantage at these positions, I'll go to the side port, come over here and do it at 2 o'clock position or 12 o'clock position through the side ports. So wherever I have capsule advantage, I will go for my Rexis there. If I have uniform capsule advantage, then I'll go for the conventional 8 o'clock position and 4 o'clock positions for my hydro dissection. So I had used the 0.3 mils. There's no how I will have a blowout of the capsule. That also means anytime your assistant throws an instrument at you, please look at it carefully. If it is not your safety instrument, please kindly return it back to them, please. So I've done hydro dissection now. This is confirmation that the nucleus is totally cleaved from the bag. Surgery can now start. Okay, I think that's another hydro. Okay, this is visco just achieve a depth, allowing me to introduce my fecal hand tip and the second instrument. Okay, another hydro dissection. Let's look at this. I have uniform capsule advantage. I'm going to 8 o'clock position, advance in. All right, you can all see that. Let me see if I can take us back. Watch. The fluid wave, steady the hand. All right, beautiful. That is it. That is it. 4 o'clock position, steady the hand. That is it. So we're good to go. That means the nucleus is free from the capsule. Achieve a depth for introduction of instruments. So far, so good. So we can continue like this. All right, so let's look at this white cathode. Someone asked a question about double Rexis and spiral Rexis. I think I did a double Rexis here. Let's see what happened here. So just me touching it, because of the high intralenticular pressure, I had started losing the capsule. So I used initial centripetal pull, then tried circumferential pull, and finished up with a centripetal pull. What determines which I will use, whether circumferential or centripetal, is the circle that is forming around me. Now that is fluid going in, I'm engaging on aspiration. Without aspiration, I am adding extra fluid. All right. This is not good. Whenever such collapse occurs, the endothelium is going to hit on your instrument. And that is central visual area. So if you have any hazy cornea the next day, vision will be affected more. If it is peripheral hazy cornea, the person can come back in 1 week and vision would have come back. But in this case, you have to decompress. Now the question is, how or when would you say you've done enough decompression? Theoretically, when the dissolved cortex has been absorbed, theoretically, but then you're still a surgeon to make the decisions on table. Even if you've not removed all the dissolved or liquefied cortex, even if all the dissolved or liquefied cortex is not yet aspirated, but as a surgeon, you can use your judgment to know that this bag I am looking at is no longer under tension. So I can continue my Rexis and complete my Rexis without putting this bag under undue duress. So theoretically, one is said to have done enough decompression where the liquefied cortex that you can see has been aspirated. But as a surgeon, your judgment at this moment is important, as long as it doesn't give us Argentina flag sign. The reason is simple. Why you have to use your judgment, because if this capsule you are seeing has weak zones and you want to do a thorough decompression of the liquefied cortex, well, that also will come with some challenges, because when that is done, you will now start managing the weak zones. So I am leaving the eye on aspiration mode. If not, the fluid that is leaving my simple will always go back. So never leave the eye on fluid only mode. Engage in aspiration. So you don't recompress the interlenticular space. The pressurization of the anterior chamber is done behind that interlenticular opening. And the reason is simple, so that you don't recompress it. So this is the second rhexis. Remember what we said. Whatever happens during capsulorrhexis, we follow through and through the rest of the cataract surgery. I foresee a problem already. So this is the spiral component of the rhexis. I went behind or beyond the margin. Wow, that's already a problem. Okay, see what I was trying. I foresaw a problem occurring. So now with this rhexis now, I don't have capsular advantage on nearly half of the eye, while I have good capsular advantage on one half of the eye. This will follow me throughout nucleus management. It will also follow me throughout cortical washout. It will follow me throughout IOL implantation. Okay. What was going on effortlessly well has become a nightmare to me. Okay, let's see what happens finally. This is another white cataract. These were the reasons why I said it is not fair to give a beginner a white cataract to manage. White cataract in itself is already a problem. When we are doing nucleus management, we will discuss the tunnel length. Tunnel length different from the incision length. Incision length is what you can see from sclera to sclera. Tunnel length is from sclera into clear cornea. How long is the tunnel? This eye was a post-traumatic cataract. I had stained the eye with triamcinolone to be sure there was no vitreous in the anterior chamber. So from the one I'm doing centripetal pull, this is not a case for circumferential pull. So from the inception, I am doing centripetal pull, and that was what it gave to me. I did not anticipate having that, but because of the high intralenticular pressure, the capsular bag is always under high pressure. So any unnecessary motion of the capsule. So this is centripetal, and this is what I get. So in white cataract, always anticipate very high intralenticular pressure. And my advice is always go for centripetal pull. If the tension as adjudged is no longer there, then you can do a spiral rhexis. So from the main incision, centripetal, from the side port, centripetal. So I've gotten myself the first rhexis. The next thing to do is to decompress this intralenticular space of the liquefied cortex before continuing with your expansion of the rhexis. Engage on aspiration immediately. You are in front of the intralenticular opening. If you're in front of the lenticular opening, please engage in aspiration. Extra fluid. Okay, I think I will. There's a video I have about that. I was just talking with my assistant. I didn't even know what I did. The thing just busted on me. I have a feeling that the video is here. So that momentary distraction I should have engaged on aspiration. But momentarily, I lost concentration, and next thing I saw was Argentina flag sign. Every white cataract, please anticipate other problems. Any white cataract one is seeing, please anticipate other problems. And the one that is so easy to anticipate is that this eye has not been seen. And there are possibilities that this person has been nudging the face against hard objects like the wall, the door, because obviously there's poor vision on that side. That also means anticipate weak zones. Anticipate weak zones. Anytime there's white cataract, it's a pointer that there could be other problems. It's always good to prepare for the worst. If that worst is not there, then you can take a breath of relief. By my judgment, I think this has been decompressed enough. Of course, the liquefied cortex has not been all aspirated, but that was my judgment at this moment. And like I will always say, if this is your judgment, you're right, I'll support you because you're the one on table. Okay, now see what I'm doing. You might mistakenly think I poured it into the intralenticular space. I did not. I poured it underneath the endothelium. I could rewind it back, but let's allow it play. So you could see that I wasn't directing my visco into the capsule. I directed the visco into the endothelium, I mean, towards the endothelium. I had to achieve, as it were, adequate size depth of the anterior. Okay, look at what I did now. That extension is long. I pray I don't lose this. So that extension I did was long. Let's see what happens here. Firm grab, motion down. Okay. All right. Okay. That was safe enough. So the rest of the nucleus management will be safe. So I have adequate nuclear capsule advantage between 4 o'clock position to nearly 8 o'clock position. So this is another white cataract. Let's see what happens here. Thank you. Your tunnel length should at least follow the recommended textbook prescription, which is 3 millimeters to 3.5 millimeters. And that recommendation is estimated by 2 millimeter incision from the limbus on the sclera, and also 1 or 1.5 millimeter incision into the clear cornea. That's how the estimated tunnel length came about, 3 millimeters or 3.5 millimeters. So it becomes adequately self-sealing. So I have a small rhexis. This is small. I must definitely decompress adequately. If not, any second rhexis on this case will still be problematic. Because we are decompressing a previously turgid capsule, that means we should expect wrinkling of the capsule underneath. We are decompressing a previously stretched out capsule. That means you should expect a wrinkling as that decompression is going on. And that wrinkling simply means as you aspirate, it will come and occlude the aspiration port. So in as much as you are wondering, why am I not aspirating the liquefied cortex? Because of the wrinkling. The capsule wrinkles and obstructs the port. So you want to do it, you can't do it. You want to do it again, you cannot do it. So this is where patient now calls for action. Patiently aspirate. If you can, avoid the pot. Just tilt the pot a little away from the raincoat capsule because it will always be occluding your view. Talking about difficult rexes, I think I had difficult rexes today. I think I had difficult rexes today. The video is not here. I'm sure a lot of you would have laughed at me, but I overcame. I conquered the eye. That's the final story. But did I suffer? Yes, I suffered. That also means there's no part of rexes, even if it is effortless, there's no part of rexes that is easy. How would that prevent rexes from going out of prediction? Number one, check your speculum. Let's even start from the enemy within that we not easily recognize, the speculum. Can anybody tell me what is going on here that is wrong? My visco is going into the interlenticular bag. My visco just went into the bag. And I can tell you this is not unaware. I never saw this before. I'm just seeing this for the first time now. My visco went into the bag. So all my decompression has been countered by the fact that I put visco back into the bag. And that I knew because the bag was ballooning out. Let's see what happens. Okay. Raincoat capsule. Raincoat capsule. The first thing that you should look at is the speculum. I don't know if in all cases you'll be the one to do anesthesia for yourself. But if another person did anesthesia for you, I will suggest take out 1 minute and do a massage on the eyeball. Massage on the ocular massage is not body massage. Ocular massage is just a steady but firm pressure on the eyeball, please. So when they say massage, it's not body massage like a spa, no. So it's just a firm, steady pressure on the eyeball. So if you're not the one that did the anesthesia, I think the best advice is to do a little massage on the eyeball. So you can dissipate the fluid as accumulated beneath the eyeball into the subcutaneous tissues or into any tissue around the muscles and the rest. And then let it, if possible, let it leave the orbit and come and form a swelling around the eyelid. That is number one. Make sure that there is no induced positive vitreous pressure behind you. All right, so the second to do is make sure that the speculum is not too firm on the eyeball. If the speculum is too firm on the eyeball, slack it a little. Look at the patient. If the patient has big abdomen, then it's wise to ask the patient to put the hands by the side. If the patient tucks the hand against the abdomen that is big, that's going to be a pressure. With each breathe in, breathe out, you will notice the eyeball will shallow on you. The anterior will shallow on you with each breathe in, and you find yourself putting in visco. Sometimes it's a good judgment to even stop surgery and ask for help. It's a good judgment sometimes to stop surgery and ask for help. So even if you need to set up a monitor fluid, please set up monitor fluid. If it comes to the point of delaying surgery 1-2 hours, please, there is wisdom in doing so. If it becomes very difficult, let the person take Diamox tablet and wait about 1-2 hours and pee enough. At least pee twice or 3 times, and then surgery continues. To the best of my knowledge, yes, I'll take the blame for delaying surgery, but at least I'll have good outcome. That's my own thinking in this matter. If you can set up monitor, please set up monitor and let the patient know that it's going to be messy down there, and decompress. So we have looked at two things. One is the anesthesia you use. If you use large volume of anesthesia, it's going to make it difficult to have a soft eyeball. Now, if the speculum is too tight, you have to slack it so that the pressure, external pressure on the eyeball will be less. And that is to say that pre-operative management was properly done to factor in reducing the intraocular pressure. Then apart from that, a combination of dispersive visco and cohesive visco to achieve adequate anterior chamber depth at each one time. Adequate anterior chamber depth at each one time. For those watching this video, you'll be wondering, what have I been doing? After the initial puncture, liquefied cortex came out and filled up the space. I wasn't even seeing anymore. So what I did was aspirate the ones too obvious. Then I went behind the bag. The more you tap, the more the liquefied cortex will come out. The more you tap, the liquefied cortex will come out. I can only see the flap that I formed. So I'm going to go for the flap, advance it round and complete my rexis, since I've already removed the liquefied cortex. Hold firmly. Right. So I'm still doing my centripetal for fear of radialization. So I'm going back again to decompress further. In this case, I'm happy to spend longer time in the eyes. And let's even be sincere with ourselves in this matter. Assuming I did can opener capsulorrhexis, I would have finished the surgery by now, but you and I know better how the outcome would look like. So what I'm trying to do is this. In the event this eye requires a capsular tension segment or ring, I have a capsule to do that. In the event this eye requires any further maneuver, I can do that. Now, there's no harm in doing SICS and putting yellow foldable double aspheric IOL. If you cannot find the capsular margin to do that, then you can't do such maneuvers. So in this scenario, I am a proponent of take your time, just make sure the eye is safe. Even if the eye is not safe for you to finish, let the eye be safe for another person to finish. Example, if I'm sending this person to the vitreoretinal surgeon, let me leave a seeing eye for them to manage. If I'm sending this patient to the glaucoma specialist, let them also have a beautiful eye to fly their trade on. Okay, so remember what I tried explaining, the reason for the wrinkling. The wrinkling is because the previously expanded capsule is not being decompressed. So each time you want to aspirate liquefied cortex, the wrinkled capsule will come in the pot. So the best way is to see if you can do that, tilting the pot sideways. This motion I just did now is easy to watch on video, but if you try it in real life, you know, if you don't have, you know, little, how will I put it here, safety consciousness, or if your zonals are not weak, if we do that, then you might put yourself in the trouble. Okay, so far so good. I think we have decompressed enough. Theoretically, I've not done adequate decompression, but then surgically on table, I've removed the initial liquefied cortex, which took me time to remove. I've done my initial small rexes and I've decompressed further. So surgically, I can give it to myself that I've done adequate job. But theoretically, I've not finished the decompression. So that was what I was saying. Theoretically, when is decompression said to be completed? Yes, the liquefied cortex that is before you, when you remove it, then it's said to be done. But as a surgeon, your decision on table matters. Okay. All right. So surgically, I was right because there's no more intralenticular tension. So I was able to do adequate rexis with spiral rexis in combination. All right, thank you. Let's look at this and see. Achieve adequate tunnel length. All right, so this is probably a tunnel length of 3 millimeters, if I am correct. I think I'm correct. So I don't know if anybody noticed the way Visco poured out M block. That's one bad sign. I don't know why I did not notice that sign. So it has now left me with a very small initial rexis, smaller than anticipated. Okay, so let's look at what happened. I think this is one I had the problem. Try to, again, M block loss of visco. I don't know if anybody noticed that. It just came out M block. I'm trying to see if I can get something bigger to work with. So this is still why I said it's not a good decision to give a new person in cataract surgery white cataracts to manage. Okay. Small opening. Now I'm aspirating. What happens? Is blocking the view. The more I aspirate, the more the wrinkle capsule comes in my view. Fluid, meanwhile, is going in. All right. You now see what happened? Argentina flag. Congratulations. And this will follow me throughout the surgery. How did I come about Argentina flag sign? Reason was this. My fluid was repressurizing the intralenticular space. I did not have adequate aspiration to counter it. So I'm doing just trying to see if I can remedy this scenario. Now, let's be sincere. This will follow us throughout nucleus management. I included this video in nucleus management, so we can see how we manage it. It will follow us during cortical management. It will follow us through IOL implantation. So ask me again, which are the most important two steps in SICS? I will tell you incision is the most important uh, step in SICS. Incision, as simple as it sounds, yes, incision is the most important, followed by your capsulorrhexis. Those are the two things that will follow you from the beginning of surgery to the end of surgery. Incision and capsulorrhexis. Why is incision more important to me than capsulorrhexis? If I have done nice but small incision, and I've done nice capsulorrhexis, and it's time for nucleus delivery, there's no space. You will burst the capsule also. So what was nice capsulorrhexis, capsule well protected, but there's no space to deliver a large nucleus. All right, so let me see, okay. I think I included in the nucleus management video. There's another video for nucleus management, please. Okay, so you could see this tunnel length is longer. This is probably almost 4 millimeters tunnel length. That also means this. There's no way there will be iris prolapse in this case. It is practically impossible to have iris prolapse. It's not possible because the tunnel length is such that when it opposes back on itself, it can never allow any iris to come out because iris root is far from it. I think I have a firm grab now. So I'm going for centripetal. Wow. So the decision to be made here now is this. How do you finish up these rexes? How will you finish up these rexes? Assuming in hindsight, I would have used scissors to engage somewhere here about 9 o'clock position here. I will engage somewhere here about, I won't go towards 6 o'clock position because it's far from me. In the event of any danger, I'm not sure I'll be able to rescue myself if it is far from me. So if I'm going to do any rescue maneuvers, I will go to where it's closer to me, 3 o'clock position to 9 o'clock, 9 o'clock, 3 o'clock position, or towards 12 o'clock position. But that is in hindsight. But let me see what I did here. Okay, what I did. All right, so that was fair enough. Someone will always tell me dry aspiration. Trust me, I've tried dry aspiration. I don't think it's good to be recommended. Let dry aspiration be your decision as a surgeon when you have weighed every option before you. Let dry aspiration be your decision as a surgeon after you have weighed every option before you. Obviously, no two eyes will give you the same scenario. So if what you're saying is that the anterior chamber is well pressurized enough to allow dry aspiration, then go ahead and do that. Looking backwards from experience, I don't think I'll be a proponent of dry aspiration. Not at this point. I can do dry aspiration maybe somewhere else, but not when I'm trying to decompress a highly um, elevated intralenticular pressure. Okay. This is fair enough. It's fair because I can see the opening margin and the extent of the margin. So if I lose this capsule, then I just lost it out of carelessness. But I think so far so good. So that's a combination of centripetal and circumferential pull. I left it very close to 12 o'clock position where I can grab it. Okay. Went for the base of the flap. Whoa, whoa, something is wrong again. So whatever has happened now will follow us throughout dust management, will follow us through cortex washout, will also follow through IL implantation. And there's no how any haptic can be in this position of capsular disadvantage. That means the IOL implantation will be at this place to straddle this disadvantaged capsular area. So that's with micro scissors. I'm cutting the flap now. So yes, micro scissors can use to complete um, Rexis. I'm not sure I have this video. The one I did Rexis from beginning to end in micro scissors because of the widespread nature of the capsular calcification. My judgment at that moment was any pull or pull will put me into trouble. So I use the the scissors to cut it out through and through. That was when I said I made a 4 point, a 4 point paracentesis with a keraton at 12 o'clock, 3 and 9 o'clock, and then 6 o'clock position. This is another one. Let me put fast forward this. Okay, this one gave me good axis. All right. Let's look at this. This one should give good axis. Tunnel length, very important. All right, so I have about 2 millimeters on the limbus. So this is probably 3.5 millimeters. Anytime I do more tunnel length inside of the clear cornea, then know that I did not get it right on the scleral base. So if the sclera is 2 millimeters, I always aim at tunnel length inside cornea about 1 millimeter, 1.5 millimeter. So when you see me do more tunnel length inside clear cornea, know that I had difficulty in doing such on the sclera. Okay, so this is a relatively good rexis for phaco. All right, I think so far so good. Dr. Norat, please. So far so good. I think we had enough of horror movies this evening. I didn't intend to show us horror movies. Please, I don't know those who are there. Please type horror movie for me, horror movie. Dr. Anya showed us horror movie. So, horror movie by horror movie by Dr. Norat.
Thank you so much, sir.
Please, thank you very much.
Thank you, sir. It's been a very wonderful evening. You've cleared a lot of doubts, and I'm sure everybody will go back, practice and practice till we make headway, a good one, by God's grace. Thank you so
Nora,
much, sir.
Nora, please, permission to say this. I have been going through my mind if my initial statement I made was appropriate. When I was advocating our having our wet labs or dry labs in our houses, I think I should reinforce that. I stand without my proposition. And if you have the permission, I would like to reinforce that it is safe, it's okay to have your own personal, private wet labs. Depending on the institutional wet labs, I don't know how efficient that will be. Reason is simple. If you had an animal eye in your house now and we're watching this, I'm sure you can reproduce your rexis this night, about 10. That's how intentional anybody could be. In fact, the word 10 teachers simply means a factor of 10. 10 minutes, 10 hours, 10 days, 10 weeks, 10 videos, 10 surgeon mentors, whatever it is you want to do. Just see, by the time you multiply it in a factor of 10, likely you're going to achieve some form of mastery. At least you will not be a complete novice in anything you want to do. That is my own suggestion. I would like to reinforce that. Someone is asking what are the contraindications to continuous curvilinear capsulorrhexis. Now, that's a question that I don't know how to answer that question. It's like saying, is there any contraindication to doing cataract surgery? Any difficulty or challenge can be overcome if we have the right instruments, if we have the right techniques, can be overcome. So if the eye has been deemed and scheduled for cataract surgery by the surgeon in clinic, it's assumed that the theater has adequate skill set and adequate instrument set to proceed with CCC. Asking if there's any indication not to do CCC and do canoplan, it simply means we don't have adequate instrumentation for that. Instrumentation here can be laser guided. Instrumentation here can be my Oatly phaco machine has a capsulotomy tip, which if I set it on, it has a regular and the other one, which I use for children. Immediately just set it, it bubbles quickly, so hot, I can easily do it. So what would have been a contraindication is just because we're in Nigeria. So outside this place, I'm not sure there's any contraindication. That contraindication for CCC is enough contraindication not to operate. Yesterday on Monday, we were discussing and the advances in cataract surgery. Someone said, and I quote, time will come where we may not need 5mm Rexis anymore because it's not necessary. Time will come where we'll find a way of liquefying the cortex or the nucleus and aspirating it through a 3mm Rexis or a 2mm Rexis and inject our foldable IOLs. So it's possible that 2040, nobody's talking about 5mm Rexis, whatever we're doing now. It's possible. So that question, I think, if you had anybody had a lesser assistance, we will not be talking about contraindication to CCC. If your phaco machine has a Capsulorrhexis tip, then the contraindication for CCC will not apply here because you need to see a visible capsular rim to do further maneuver in supporting the capsule. There is this argument that the best position to put the intraocular lens is still the capsular bag. Every other attachment, whether you apply it on the iris or you do scleral fixation, is not the ideal position. So the surgeons are still insisting that the ideal position is still in the bag. All right, thank you very much, please.
Thank you very much, sir. Do we have any other questions, please? Somebody's asking another one. Do you necessarily have to do hydrodissection
Let me see the question.
when you have Argentinian flag sign?
No. Anytime that you've decompressed the intralenticulaar bag, there is no more need for hydrodissection. The reason is simple. The cortex has on its own liquefied. You only escorted some or all of it out. So the endonucleus is already free floating. So there's no need going to do hydrodissections anymore. Hydrodissection is usually when, as it were, everything went on effortlessly. Please, can I make a little comment? Usually when I do 10 teachers, I do give out some little 1 or 2 questions and answers. Would it be fair if I drop here a questionnaire, as it were, to just get a feeling or feedback on how this stuff has gone? Dr. Nora, please, and Mustafa, I don't know if I have the permission for that, please.
Yes, sir. Go ahead, sir.
It's okay. So Dr. Nora, I can forward it to you so you can deploy it officially, please, if you don't mind.
Okay, sir. All right. I don't think we have any other questions for now. So let's make it tomorrow again, 8 p.m. And then we continue with the steps in small incision cataract surgery. So, sir, that means we have nucleus management.
Yeah, definitely nucleus management. Tomorrow is to do nucleus management. Next tomorrow will be Friday. Let's see if we could do cortex, IL implant, so that on Saturday we'll be doing the main reason for 10 teacher, which is surgical video editing. Someone is asking a question. Okay, that's fine. Thanks for that. Oh, Mustafa, please, thank you. I'm grateful for the permission, please. All right, thank you, everybody.
Thank you. Thank you, sir, for the amazing session. Thank you, everybody, for joining in. Let's do this again tomorrow night by 8 p.m. Thank you. Please enjoy. Have a good night's rest.